let's go ahead and get started. Thank you for those of you who braved the weather that you don't have to get there. I'll ask first if there are any requests for bill introductions. Okay, I don't see any.
Yes, ma'am.
Oh,
yes,
yes, I do.
Yes.
Is that Willie? Hi, Willie.
Yeah, to look at you, you're behind me, so you know it's a little different angle
Yeah.
here. But no, I do have one today. I'm Willie Prescott, Special Assistant to the Attorney General. Chairwoman Kincannon, members of the committee, thank you for the opportunity to request this committee introduce the following bill at the request of Attorney General Derek Schmidt and the Elder and Dependent Adult Abuse Prevention Advisory Council. It's 21 RS 0127. And it's a bill creating an elder and dependent adult abuse multidisciplinary team coordinator and a elder and dependent adult abuse multidisciplinary team. We'd appreciate you considering this request, and we'd stand for questions.
Anybody have questions for Willie? All right. Are there any objections for this request? All right, seeing none, without objection, we will request the introduction. Thank you, Willie.
Thank you.
Do you have any more? Okay, anyone else? We're going to get started, but I have in other committee meetings that we've had where we've had some people that are remote. There's been a little bit of difficulty seeing when someone has questions. So I just thought I'd tell you, if you go to the down on the bottom right where it says participants and find your name, then there should be an opportunity to raise your hand. And you can click that there. I don't know how I'm going to see that, but that's how you do it.
Madam Chair, I'll try to keep an eye on it.
Thank you. I might, Charlotte, or Representative Esau, I might have you just facilitate that when questions come. Okay, so the only thing we have on our agenda is a presentation by Michelle Ponce she's the Associate Director of the Association of Community Mental Health Centers of Kansas. Is Michelle there in person or do we have her virtually?
I'm here virtually.
Okay.
How's the audio for you?
Well, it sounds good from my end. How is it in the room?
We're good. Good.
Okay. All right. Well, welcome to committee, Michelle. We'll turn it over to you.
Thank you. Madam Chair and members of the committee, my name is Michelle Ponce, and I am the Associate Director for the Association of Community Mental Health Centers of Kansas. Thank you for the opportunity today to provide information about the Kansas Community Mental Health System. Our association represents all 26 licensed community mental health centers in Kansas. Chapter 19 of the Kansas statutes established CMHCs, or community mental health centers, as the county designated treatment entities, and as such, they are the local mental health authorities. Each community mental health center serves a defined geographical service area that we refer to as a catchment area, and they provide services in all 105 counties. CMHCs provide services to all Kansans needing them, regardless of the ability to pay. This makes the community mental health system the safety net for Kansans with mental health needs. Community mental health centers strive to provide quality care, treatment, and rehabilitation to individuals with behavioral health problems in the least restrictive environment, meaning treatment at the community level in order to allow individuals to continue functioning in their own homes and communities at a considerably reduced cost to them, third-party payers, and taxpayers. They provide treatment and recovery services to Kansans covered by Medicare, Medicaid, private insurance, as well as those who are uninsured or underinsured. Historically, mental health services were primarily administered in state and private psychiatric hospitals on an inpatient basis. In 1990, the Kansas Mental Health Reform Act fundamentally changed the mental health system in Kansas with the goal of transitioning care from institutional services to community-based care. This was to be accomplished by making community mental health centers the gatekeepers to the state psychiatric hospitals and to community-based services, which increased the number of patients served in the community and reduced hospital use. The Mental Health Reform Act provided phased funding to community mental health centers and state hospital catchment areas to enhance screening services and triage, or as we sometimes refer to it, gatekeeper services, to ensure that patients receive the appropriate services in the appropriate setting. The legislation mandates that no patient shall be discharged from a state hospital if there is a participating CMHC served in the area where the patient intends to reside without receiving recommendations from such participating mental health center. Each center has one or more liaisons who go to the state hospitals to assist with discharge and aftercare plans, as well as coordinating with private psychiatric facilities and nursing facilities for mental health. We commonly refer to the state funding for community mental health centers as mental health reform dollars. And while the demand for community-based services continues to grow, funding for these services has been cut significantly over the last decade. Leaders in the legislature stepped forward to begin the process of restoring the promise of mental health reform by partially restoring CMHC contract funding in 2018, 19, and 2020. Then the 2020 Kansas legislature approved an increase of $2 million for FY21. However, that was later deleted through the process of allotments. Currently, state contract dollars equate to the 2006 funding level. Now, the estimates used for number of persons served by CMHCs back in 1988 as the state was preparing for the transition to mental health reform was 80,000. Per the state automated information management system, CMHC served over 145,000 Kansans in state fiscal year 2019. That's over an 80% increase in that time period. In terms of accountability, every CMHC is accountable to an elected or appointed board of directors. Each of these boards is then accountable to the citizens they serve, their county officials, the state legislature, and the governor, and all have reporting responsibilities to the national level of government as well. It's important to note that the Kansas mental health system is a relationship of shared governance between state and local government. CMHCs are licensed through the State Department of Aging and Disability Services, and it's that licensure that requires them to provide services to all Kansans needing them, regardless of ability to pay. In addition, state contracts with centers have specifically delineated outcome performance measures since mental health reform. The CMHCs also complied with Medicaid and Medicare standards and audits. The community mental health system is not self-contained, but rather one that reaches across many other systems. The CMHCs integrate and collaborate with systems at the local level, such as education, juvenile justice, developmental disabilities, corrections, aging, child welfare, hospitals, physicians, and law enforcement. At the state level, CMHCs interact with KDEDS, DCF, KDHE, Department of Education, Corrections, and in recent years, even the Department of Agriculture, as they've collaborated on suicide prevention efforts specifically targeted towards farmers in our rural areas of the state. Now, as stated previously, it was implementation of mental health reform that shifted the focus from community mental health centers from preventative short-term care toward a community-based system with the ability to provide long-term treatment and care, as well as case management and crisis services. As a result of the shift in funding, some of the early prevention programs have been reduced. Though in recent years, the legislature and other partners have helped to restore funding for priority prevention programs, such as mental health first aid and suicide prevention programs. Our community mental health centers have now implemented these programs in all areas of the state. Even with the focus on community-based care, there remains a great need for inpatient psychiatric services. Kansas originally had state mental health facilities in Osawatomie, Larned, Topeka, and Kansas City. With the closure of Topeka State Hospital and Rainbow Mental Health Facility in Kansas City, the state currently has 2 remaining state mental health hospitals in Osawatomie, which serves Eastern Kansas, and Larned, which serves Western Kansas. In 2015, the Secretary of KDEDS placed a moratorium on all voluntary and involuntary admissions to Osawatomie as a result of the decertification of the hospital by the Federal Centers for Medicare and Medicaid Services. The moratorium has placed an even greater strain on an already stressed network of CMHCs that are responsible for assessing the need for admissions. When a bed is not available at Osawatomie, the responsibility falls on the respective community mental health center to maintain the patient in a safe environment until a bed becomes available. This can sometimes take days and has been an additional responsibility placed on mental health centers that did not occur prior to the moratorium. In addition, over the past year, Larned State Hospital has also reached maximum capacity multiple times, in essence, creating a managed moratorium for that area of the state as well. Reductions in state psychiatric inpatient budgets, coupled with funding reductions in mental health reform dollars, have resulted in our system being strained and continually asked to do more and more, including now assisting in managing a waiting list of over 100 youth who should be treated in psychiatric residential treatment facilities, as well as assisting with managing moratoriums at both state mental health hospitals. At the same time, we've been closely monitoring and reporting on 3 crises since at least 2017. These are the rising rate of suicide, increasing child welfare caseloads, and the opioid epidemic. The statistics around suicide, and especially youth suicide, are of great concern to our association. Thankfully, the overall number of deaths by suicides decreased from 2018 to 2019. However, the second leading cause of death for individuals aged 15 to 44 remains suicide. And here I am going to apologize because I did not discover this typo until I'd already sent you my testimony. But based on our recent reported numbers from 2014 to 2019, our state experienced a nearly 50% increase in deaths by suicide in the 15 to 24 age group. I apologize that my written comments say 5 to 24, but that should be 15 to 24. At the association, we monitor the annual publication of the Kansas Annual Summary of Vital Statistics from KDHE, and we've created the graphs I've included with my testimony to provide you with a visual of the total rate of deaths by suicide in Kansas from 2014 to 2019, as well as a breakdown by age group. These data really drive home why prevention programs are so important and why community mental health centers are focusing on suicide prevention activities at the local level. I'd like now to shift and talk just a little bit about the impact of the COVID-19 pandemic on community mental health. For sure, the pandemic has made it clear that community mental health centers are essential service providers and that mental health treatment and services are a vital part of a community's healthcare service array. During times of crisis, the need for services due to increased rates of anxiety, depression, and social isolation grows. The CDC published a recent report last fall, I believe it was in November, that compared the time period of April to June 2019 to April to June of 2020 and found higher rates of adverse mental health conditions, substance use, and suicidal ideation in 2020. Further, the prevalence of anxiety disorder had increased 3 times what it was in 2019, and the prevalence of depressive disorder was 4 times higher in 2020. Throughout the pandemic, our community mental health centers have been actively engaged in planning and developing policies designed to keep both their staff and their patients safe, and they've worked tirelessly to ensure access to care through an innovative means, including telehealth. In fact, this past spring, community mental health centers abruptly changed the way they did business in about the time period of 2 weeks and went to nearly 100% telehealth services. This was done for several reasons. First and foremost, to promote safety and protect the health of patients and staff, but also to ensure continued access to mental health and substance use disorder treatment, to maintain connections with patients, and to minimize the effects of the social isolation, and also to ensure the financial stability and sustainability of community mental health centers who are experiencing the economic impact of the current crisis. Around middle of summer last year, most mental health centers in different phases and different kind of processes have reopened to face-to-face services, but all are now providing some mix of continued telehealth as well as face-to-face service delivery. The economic impact on mental health centers through the pandemic in terms of lost revenue as well as unexpected costs has been $37 million since the emergency order in March through November. This amounts to over 15% of the annual CMHC system budget that has provided treatment and services to a record number of patients over the last several years. The CMHCs have been able to recoup some of this loss through a combination of public and private grants and federal programs, as well as federal funding. To date, KDADS has allocated $14.2 million worth of CARES funding directly to community mental health centers. We're very thankful for this support, but we also recognize that the impact of the pandemic is far from over, and the consequences and financial strain will continue well into 2021, if not longer. While we are hopeful that we're nearing the end of the pandemic's threat to the physical health of our communities, we know that the mental health impact of stress, trauma, and isolation will continue for quite some time. Looking forward, the ability to continue providing telehealth services is vital. During the public health emergency, CMS has allowed more flexibility in providing these types of services, including services to being allowed to be provided via telephone and not just televideo. Anecdotally, community mental health centers have reported to us that due to telehealth, they've seen an increase in kept appointments. Telehealth also helps to overcome long-standing barriers such as lack of transportation. In addition, some staff as well as patients remain apprehensive about returning to traditional face-to-face services, and telehealth helps to ensure continuity of treatment in these situations. Recently, the governor has included $5 million for mobile crisis response services and an additional $3 million for family crisis services. Both the 2017 and 2018 mental health task forces recommended expansion of crisis services to provide targeted interventions and emergency care and treatment for individuals experiencing crisis due to mental illness, substance abuse, or co-occurring condition, ultimately with the goal to reduce inpatient admissions and divert individuals from waiting for care in emergency departments and jail settings. The governor also recommended enhanced funding totaling $2 million for specialized services to be provided to residents of nursing facilities for mental health. These facilities provide residential care and rehabilitation treatment for older adults who meet the functional eligibility requirements for nursing facility care and also experience severe symptoms of mental illness. Looking at the other end of the age spectrum, we're also looking forward to continuing the successful Community Mental Health Center Education Partnership that was forged through the Mental Health Intervention Program that was originally created through legislative proviso in 2018. And this program is meant to address challenges schools were experiencing through increases in students with mental health needs and to eliminate barriers in accessing services. Currently, there are 56 school districts partnering with 17 community mental health centers on this program that allows our schools to focus on education and our CMHCs to focus on treatment and improving care, including the ability to provide 24-hour crisis services. Student outcomes have been outstanding, with over 70% of students served during the 2019-2020 school year showing improved attendance and behavior, and of over 60% achieving improved academic performance. Lastly, I've already mentioned the increased demand for services and stagnant reimbursement rates that have been straining our system. So I'd like to speak briefly about one potential solution that would allow us to commit sufficient resources to ensure access to a comprehensive range of mental health and substance use disorder services, and to provide our Kansas Community Mental Health Centers the ability to recruit, retain, and adequately reimburse the mental health professionals needed to provide these specialized services. That is the implementation of a new service delivery model referred to as the Certified Community Behavioral Health Clinic, or CCBHC model, which provides an integrated service delivery model with a sustainably financed model for care delivery. A recent report from the National Council for Behavioral Health lists the challenges that CCBHCs were specifically designed to address, including the suicide crisis, overdose deaths, barriers to timely access to addiction and mental health treatment, delayed care, inadequate care for veterans, overburdened jail and emergency departments, and decades of funding cuts that have led to workforce shortages and providers struggling to meet the needs of the communities. all of which affect the Kansas community mental health system. Our mental health centers have demonstrated both an interest and a readiness to move toward this model of care, and we've been exploring options for implementation in Kansas. While there remains some additional education and planning that would be required, we do believe there is a viable path forward and that this model will help address many of the aforementioned challenges our system currently faces. With that, I would leave you with one last statement, and that is that it is our goal to continue to be providing the best mental health system in the country, providing high quality and innovative services to Kansans. Thank you, and I am happy to stand for questions.
Thank you, Michelle. Committee, do we have questions? Vice Chair Esau, are you in? Can you facilitate the questions?
Yes, Representative Neighbor has a question.
Thank you, Madam Chair. And thank you for that excellent review today, Michelle. It was very helpful. My question to you is, when we started using telehealth or telemed with mental illness patients, does it afford, do they have the same reaction to doing it online as if they were sitting in front of you? Do you see a difference in that?
So I think what our experience, especially in this past year, well, and I should say to begin with, telehealth has been used for decades in some areas of the state. What has changed in 2020 are additional flexibilities. Some of those include, as I mentioned, the ability to provide therapy over the telephone versus requiring it to be televideo. There have been some flexibility in terms of the point of service. So as mental health centers, like pretty much everyone else in the state, have struggled with maintaining an adequate workforce on site, whether that is because their staff are home caring for children who are no longer in school, or home potentially under advice of public health to quarantine due to potential exposure. It has allowed therapists to actually have an originating site at their home and to be able to continue connecting with their patients. Last summer, many of our mental health centers conducted various types of customer service surveys. And you know what they found is there's some segment of the population that really prefer that face-to-face service delivery model that they're used to. And there's also a segment, probably about another third, that are pretty flexible and either works for them. But then there's another third who have indicated that their preference is for telehealth. And I mentioned an increase in kept appointments. For some individuals, it may be a barrier to be able to drive to the brick and mortar community mental health center to meet with their therapist, or that may be a young mother at home now caring for children who are no longer in school and just doesn't have the ability or childcare available. We've also found that, yes, it is a viable and effective treatment modality. Now, I will say there are some types of services that even in the early part of the pandemic, when most face-to-face services were not happening, certain types of crisis services or perhaps administration of injectable pharmaceuticals that must be provided face-to-face. However, the vast majority of services provided through community mental health centers we've found are effective and are able to be provided via telehealth.
And if I may, one follow-up. Have you
Sure.
had any trouble having access to broadband or internet for these kinds of services? Has that limited your ability?
Certainly. Access to broadband, as we all know, has been a barrier for some time, especially in our rural areas. A couple of things related to that. Many of the funding, there have been many programs through the pandemic that have allowed community mental health centers to be able to update their technology and provide mobile devices to be able to provide telehealth. But again, there was that distinction between the new flexibility of being able to provide services via the phone that has been extremely helpful. So if an individual in their home is having, broadband issues, they can pick up the telephone right now and connect with their therapist. Or if you're dealing with a family who maybe has one laptop computer and it's now being used by their third grader so that the child can stay in school, the parents can still connect with their therapist, their community mental health center via the phone. So that's been one flexibility that's been really important.
Thank you, Madam Chair, and thank you.
Thank you.
Representative Wagner has a question.
Thank you. One or two questions. You mentioned as far as during the last year that the number of whatever anxiety situations in students went up 3 times and depressive disorders went up 4 times. I mean, it went up from 1% of the students to 3%, or it went up what's the actual number?
So that particular citation was not related to the students. It was a CDC report of prevalence of anxiety disorders and depressive disorders nationwide. And I do not have that exact number in front of me, but I would be happy to get it and bring it back to you. I apologize, I don't have that in front of me.
Okay, if I can follow up on 1 or 2 other things. The you said the community mental health centers are a safety net for everybody, that everybody has services regardless of pay. So is there a certain point which they're literally free, or it's just people don't pay and so they're free because they didn't pay? How does that work?
Well, there could be a variety of scenarios. First and foremost, those state contract dollars, those mental health reform dollars, those are to be able to support mental health centers to provide services to uninsured individuals. If an individual does not have insurance, but they do have some income, they might be charged a sliding fee scale. But it's a state mandate that mental health centers cannot turn anyone away based on their ability to pay.
Another just sort of data question. You talked about the suicide, rising youth suicide in particular. Do you break down those numbers? I mean, what's the percentage change over the last 5 years, 10 years? And then secondarily, do you break that down between youth who are in like a traditional 2-parent home versus some kid who's in a broken home or a single parent family?
So those numbers that we're citing come directly from KDHE's annual publication of the vital statistics. Overall, all age groups from 2014 to 2015, the percentage change is an increase of about 15%. In the age range of 15 to 24, in that same time period, it is 48%. I do not have that broken down by type of family structure. I believe the KDHE Vital Statistics Report give us age groups, and they also have some other demographics in terms of race and ethnicity. But as far as I know, they don't break down in terms of youth, whether they live in a single parent or 2-parent family. So I'm sorry, I don't have that information.
Ask one more question, if you don't mind.
Okay, and then we got 2 other people that have a couple questions.
Let him go, then I'll pick it up at the end.
Okay. I apologize, I'm not sure who's first, so I'll just go with the one that's at the top of the list. Representative Johnson.
Thank you, Madam Chairman. That was excellent. You gave me so much information. You spoke about veterans programming, and I'm on another standing committee, and we're working on things for veterans. And be honest, right now, our suicide rate with veterans coming back from military deployments, I think it's almost an epidemic. And so what were those services that you folks in this system are able to provide for those vets?
Sure. And I will preface my statement with that we have a variety of programs, and both in collaboration with the state and at the local level, designed to really address services for veterans. But I think what you heard, and the reference that you heard me state, was relate towards the end when I talked about the certified community behavioral health clinic. So that model, as it is defined, has 9 required services. One of them is very specific to services for veterans, in addition to general suicide prevention programs. So that model would really enhance what we're doing now and provide additional resources to continue working even more closely on services for veterans.
All right, if I could follow up just a little on that. I am in the Baser Bonner Springs area, which we are close to Fort Leavenworth and VA centers. But I sense without community centers like what you're speaking, the rural areas, that southwestern Kansas, where those veterans are at a greater distance from here, would be critical. Would comment on that?
Yeah, I mean, our mental health centers do currently provide services in all areas of the state. However, there are challenges. There's certainly challenges in our rural areas, not the least of which is a workforce shortage. So one of the challenges the community mental health centers face now is that there's a shortage of mental health professionals. We're also competing with other provider types like the VA, like schools, like primary care clinics, but also with other states. Kansas is now bordered on all 4 borders by states that have either expanded Medicaid or implemented the CCBHC model, or both. And what we're seeing is that those states that have access to the increased federal resources have the ability to successfully recruit our already in-demand workforce. And we're seeing that most specifically along the Oklahoma border and the Missouri border. In fact, there's one scenario down in Southeast Kansas where I've heard recently a mental health center CEO mention that one of his supervising therapists was successfully recruited away from the mental health center just on the other side of the Oklahoma border for about a 20-mile increased commute, but a $30,000 pay increase. And she also had no supervisory responsibilities in the new position. So not having access to those resources is certainly an added challenge to our workforce, which is already difficult to recruit in those very rural areas, especially.
Thank you so much. Thank you, Madam Chairman.
Representative Hoy has a question.
Thank you, Madam Chair. I have a couple of questions. I wondered, first off, if you could point me toward any further information on the suicide prevention efforts that you mentioned with I believe you said the USDA on farmer suicide.
Absolutely. And I will mention High Plains Mental Health Center, who serves a very large area of Northwest Kansas. They've really been a champion and a pioneer in this area, and they've had several events and have created several resources specifically targeted towards rural Kansas and farmers. If it's okay with you, I'd be happy to follow up after this and send you some information. I mean, I can tell you generally that mental health centers all over Kansas are engaged in things such as ASSIST, which is I'm going to challenge myself with that acronym, Applied Screening. It's a suicide prevention program, as well as mental health first aid. They're working with schools on things such as Zero Reasons Why campaign. So there's a variety of programs going on at the local level, but I'd be more than happy to send the committee some of the information specifically on what they've been working on with farmers and the agricultural community.
Thank you. Yes, I'd love to take a closer look at that. And then we're already focusing in on the 15 to 24 age group. And I did pull up the report from KDHE Vital Statistics, and I'm quickly trying to go through it. It's a little slow with the WebEx on my Wi-Fi too. And does KDHE or any of the community mental health centers look at means specifically, and then on to that, are there any means awareness prevention efforts that you're aware of in that manner?
You know, I'm not sure the answer to that. As I've scrolled through the Vital Statistics report, I haven't seen that, but that doesn't mean that it's not captured elsewhere. I do know that KDHE has several other data sets that may capture that information. I could follow up and check on that for you as well.
Thank you. Thank you. I'd appreciate that. And then just one more on that same issue. We're looking at 2019. Thankfully, it was going down a little bit there. Have there been any early indications what 2020 looked like for us?
In terms of death by suicide.
Oh, sorry. Yeah, in terms of especially the 15 to 24 age group, but just as your testimony mentioned that
Sure.
that's one of the 3 crises going on here, and what are I just want to know more what we can do to help there.
Sure. I don't have data yet for 2020. The vital statistics report is usually released sometime in the early fall for the prior year's data. So we don't have that report yet for 2020. From 2018 to 2019, the total number of death by suicides dropped from 555 to 521. Now, I can say we're certainly hopeful that decreasing trend would continue. It's the first time we've seen a decrease in many years. However, I think that the impact of all of the challenges that individuals faced in 2020, I would not hazard to guess what that might look like. I don't know, unfortunately.
Yeah, thank you for addressing that. I'll look forward to getting that information from you. And I really, really appreciate you taking the time today. Thank you.
Thank you.
Representative Vaughn.
Thank you, Madam Vice Chair. I just wanted to follow up on the certified community behavioral health clinic model of new service delivery. I was kind of curious what a shift to that delivery model would look like, next steps, and then what additional resources might be required for that, agency input, things like that.
Sure. And I can provide just a little bit more of a background on that. So around 2014, maybe it was 15, a little bit prior to my time in this position, at the federal level, CMS, the Centers for Medicare and Medicaid Services, offered what they called at the time planning grants to states. Unfortunately, Kansas did not participate in that. And it's only since then, only been states that participated in that planning grant activity who have had the ability to go on to become CMS demonstration sites for the CCBHC model. I believe there were originally 8, and now there's either 10 or 11 states that have implemented in that way. The important thing related to those demonstration sites is it has allowed them under Medicaid to move from a fee-based service delivery model to a prospective payment system. That's provided additional resources and is meant to cover the true cost of service delivery. Now, there are other states, much like Kansas, who did not participate in those grants and have not had the ability to become a demonstration site, but have found other ways to implement the model. Texas specifically is one. There are a couple of options there. One could be through a state plan amendment with the state Medicaid program. Another is implementation of a Medicaid waiver, using either of those methods to move to that prospective payment system. As an aside, at the federal level, the Substance Abuse and Mental Health Services Administration, or SAMHSA, last year issued, I think it was nearly 100 grants designed for implementation of the CCBHC model. And those grants weren't for entire states, they were for individual service providers. We had approximately a third, if not just a little bit over that, community mental health centers in Kansas applied for that opportunity. One of them was awarded, and that is Fort County Mental Health down in Southeast Kansas. The real importance of that is that grant actually required that applicants committed to being able to implement the new model within 4 months of being awarded, which is a pretty aggressive timeline. But what that tells me is all of those centers that applied for the opportunity last year feel like they are ready and able to implement the new model. And when I say that, that includes not just a new payment structure, that it's really about integrated care. It's about being able to provide all of those required services, which includes some level of primary care. And it's also related, it also requires certain trainings, certain evidence-based practices to be implemented. SAMHSA has recently reissued that same funding opportunity this year, and many of the centers that applied last year are planning to reapply, as well as a few that did not last year. The one shortcoming of the grant funding is it provides funding for a period of 2 years to get the center additional resources, hire additional staff, provide the required trainings, ensure that the required services are in place. But it does not come with that prospective payment system for ongoing sustainability like the demonstration sites. We've done a lot of research in this area. We do think a state plan amendment would be a good option for the state of Kansas. And I don't quite yet have an answer to you in terms of what that might cost, but we're working with several national consultants to try to get some input, kind of looking at other states, as well as doing some forecasting based on our current CMHC budgets.
That was a lot of great information. Thank you. It sounds like a really promising model.
Thank you. I should mention that that implementation of that model has also been a recommendation of the recent Mental Health Modernization Reform Committee. So they spent some time looking into it as well.
Awesome. Yeah, I've heard a lot about that, and I think that is a great possible component of that. So I'm interested to learn more. Thank you.
Thanks.
Chair, I don't see any additional questions unless Representative Wagner had a follow-up, and perhaps Representative Hoy has a follow-up. I'm not sure she has her hand. Nope, never mind. Just Representative Wagner.
Thank you for your indulgence. I had a question about the students in mental health situation, which, am I incorrect that this is regarding, it was like a test pilot program that the state started here just a few years ago? Is that what you're referencing?
Yeah.
Okay, and now, was it down in Pittsburgh, Kansas area where they were doing the trial, or there
were originally 6 community mental health centers, and I don't remember off the top of my head the number of participating school districts in that very first year. It has grown. We're currently in the 3rd year. It started by legislative proviso in 2018, and it's been expanded for 2 successive years, getting us to where we're at now with the 56 districts and the 17 mental health centers. That program is really, what it really does is it locates community mental health center staff inside the school, and the school district designates a mental health liaison. The liaison helps to identify students that might benefit from mental health services, brings them to the attention of the mental health center. And the therapist, the community mental health center therapist that's located right there in the school, is able to meet with them and work with them, is able to share strategies for in the classroom with their teachers. And we've really seen some very promising outcome measures. And the Kansas Department of Education maintains an annual report with those measures that they're tracking, and that's also available online.
Madam Chair, I don't see any additional questions in the room or online.
Okay, well, I didn't raise my hand, but I have a few questions myself. A few have already been asked. First off, if you've asked a question, could you make sure that you've gone back on mute? Sounds like there's a little bit of background noise. Michelle, when you were talking about the CCBHC model going from a fee-based to a prospective payment system, is that like a form of managed care?
I'm trying to think this through myself, and I am not the expert, so I'm going to preface that I am not the expert on financial systems. I don't think it's necessarily exactly the same thing as managed care, but it certainly can complement the managed care system that we currently have. The intent is to provide the full cost of providing services versus the fee for service that they get now. And I'm not entirely sure that I've made that any clearer, so I apologize for that. But I could follow up and try to get a more thorough answer for you.
That'd be great. I'd just be real interested in how, what is that the main difference in what you called a delivery system? Is it the difference in what we're doing now mostly just it's a different payment method?
I would say there are two main differences. One is certainly the payment method, which would bring in additional federal resources, and that's certainly important. The second is the CCBHC model is very focused on integrated care. It requires 9 essential services. It requires the ability to provide some level of primary care services. It is designed so that if a patient comes to the mental health center, that clinic is able to meet all of their needs. There's a mechanism within the model. They refer to it as a DCO, or a designated collaborating organization. So if in this example, a community mental health center is attempting to implement the CCBHC model, but they don't quite have the capacity to provide some of those required services, particularly some level of primary care that might be required, they can partner with another community organization to ensure that capacity. There are also a number of evidence-based practices that are required to be implemented, and a number of specific staff trainings that it requires. So it's both the service delivery model as well as the financing.
Okay. Well, thank you. Thanks for that. I might say any of the information that you were going to follow up with us, if you could just send that to my office,
I sure
we'll
can.
get it out to everybody rather than individuals, because I think once the question's asked, we all want to know.
Sure.
On the school program, the coordination with the school program, you said 56 currently. Are there plans to expand that even further for next year?
Well, ideally, eventually, as capacity builds, we would love to see it everywhere in the state. I believe the governor's budget recommends level funding as to what it was last year. I think ultimately whether an expansion occurs for the upcoming school year, that will be partially based on what the budget looks like when we get through the end of that process, as well as if in consultation with the Department of Education, if there's any recommendations that they might make in how the funding is divided up to those participating schools and mental health centers. I don't want to say that perhaps the current funding could allow us to expand, because I don't know that to be true, but I also don't know that it's absolutely not. But again, one of the biggest challenges in expansion is not just the funding, but it's also that workforce shortage. In order to expand the program, we have to have enough professionals available to administer it.
Yeah, and we're discovering workforce is an issue in all over the state and in every field. Let's see. I did have another question back on the CCBHC. You mentioned that we could possibly make a change through the state plan amendment. Do you know if does that require legislative action?
I don't think it requires legislative action. I know that there was a bill introduced in the Health and Human Services Committee last week related to this. And I think that bill, in essence, just states that the legislature is asking the state agencies to develop the plan for implementation. I think it could be done without legislative action, but it doesn't.
Yeah. Well, I think that a few years ago when we made the change for those amendments with Medicaid expansion, that had to require legislative approval. That I just didn't know. I can look into that myself. I think that the rest of my questions have already been asked. And then I just might mention that you were talking a little bit about the youth suicide, and we'll hear more about that tomorrow. We are hearing a review or the annual report of the Child Death Review Board.
Sure.
So yeah, we'll probably have some questions for them regarding that. So if there are no other questions in the room, Representative Esau, are there any further questions?
No further questions in the room.
Okay, all right. Well, thank you so much for joining us, Michelle. And
Thank you for the opportunity.
yeah, it was great for us to have the opportunity to find out what's all going on. If we don't have any further business, I think Representative Esau, is there anything else in front of the room?
There is not.
Okay, thank you. All right, well, we'll go ahead and adjourn then. Thanks, everybody. See you tomorrow.